Hello and welcome. This is Dr. Ezra Lockhart, and I'm presenting on a recent study, technology-driven improvements in attendance for adults with ADHD. Here's an outline of the presentation for today. I'll provide an introduction to the study, background and rationale, the study objective, methods, results, discussion, conclusions, and the references. Let's start with the introduction. ADHD, Attention Deficit Hyperactivity Disorder. This is a neurodevelopmental disorder that persists into adulthood, and there's several symptoms that are key features: inattention, hyperactivity, or impulsivity. And ADHD impacts individuals throughout various domains of life, including occupational and social functioning. ADHD impacts individuals' executive functioning. Executive functioning is skills that is required to transform thought into action, so to act in the world. And there are some marked executive function deficits. There is working memory, planning organization. In working memory, there's often difficulty holding and manipulating information that is acquired over a short period of time, and this impacts an individual pragmatically organizing and completing tasks. Same with the planning and organization, setting your goals, objectives, and initiating tasks. Additionally, there's time management and cognitive flexibility issues, so problems with estimating whether or not you can get it done within a certain time frame, making your schedules, managing your schedules, meeting deadlines, and it often results in either chronic procrastination or lateness. When it comes to cognitive flexibility, there's a rigidity to plans and strategies, and when there's new information or changing circumstances, it can be hard to be flexible. And lastly, in terms of what we were looking at in our study, there's an inhibitory control deficit in which impulsive behaviors occur, and not just individuals acting without thinking, but also difficulties in regulating their responses. So not being able to thoughtfully express themselves or preemptively consider the consequences. And this impacts decision making as well as turn taking and delayed gratification. And these executive functioning impacts that are prevalent with those who have ADHD provide particular difficulties in being able to engage in therapeutic interventions or psychotherapy, and it makes it harder for them to this population to adhere to traditional therapy schedules and to complete tasks or homework that is given to them by therapists. Let's move on to background and rationale for the study. Attendance and engagement in therapy. This is one of the major pillars that's crucial for effectiveness of treatment. Adults with ADHD within in-person therapy encounter several barriers that makes it hard for them to consistently attend therapy. They might have scheduling conflicts, again due to the executive functioning of planning organization, that they might have competing time commitments, overlapping time commitments, not remembering insufficient time to make shifts and plans. This is also the cognitive rigidity or inflexibility executive functioning deficit. Travel requirements can be hard. Again, individuals with planning issues can recall 15 minutes before a session that they need to attend and can't can't make it due to traffic, or they're not allowing enough time after their last task in order to complete their travel. Same thing with organizational challenges. It might be hard for them to adhere to the schedule. Teletherapy offers some potential solutions to these barriers. It increases flexibility as individuals can self-schedule. They have a bit more flexibility when it comes to canceling and rescheduling. There is automated reminders, so prompts, cueing, visual spatial cueing and reminders that helps individuals remember their appointments. And then, of course, as we discussed, one of the barriers is the logistics of traveling, and making sure that a person can make it to their in-person session. And it has, not just anecdotally, but a lot of individuals with ADHD will show up to sessions literally 5 minutes before the session, or 5 minutes into the session, having just woken up or in a hurry off of their last task or event. So improving attendance and engagement through teletherapy, it's known that if you increase attendance and engagement, that you're going to get more positive therapeutic outcomes. And teletherapy, again, in addressing some of these attendance barriers, will directly affect positive outcomes. Let's move on to teletherapy and its specific technological features. So, being able to remotely access intervention, remotely access your therapist, is the essence of teletherapy, being able to serve clients through a digital platform and have synchronous and asynchronous communication through video conferencing, secure messaging, as well as online scheduling. There's been an increased prevalence of teletherapy, especially after COVID or during COVID-19, in which it became a popular option, and a lot of practices either switched to teletherapy or started providing this option in order to navigate some of the state restrictions for contactless services. And that provided not just health prevention concerns, but also accessibility and convenience for traditional therapy, and eliminating, again, those barriers to travel and scheduling. There are many features of teletherapy that is available to both the counselor, therapist, and the client. When we look at those that have shown some support in attendance, we're talking about automated reminders primarily, which helps an individual manage their time, organize, reduce risk of missed appointments, as well as making sure that they're consistently attending therapy. And these functions come in the form of email notifications, SMS, which is texting, or if they have installed apps on their mobile devices, they have alerts as to what the upcoming appointments are. And these automated reminders aren't just one and done. Individuals can get at different intervals for their same session as it leads up to the session, again, to have it front of mind, and help an individual manage their time and organization. Also, flexible scheduling has been shown to support individuals across all psychiatric and clinical disorders, as well as medical disorders, which an individual can either schedule for themselves, check the availability for the next session, reschedule the appointments that they need so that they can manage their own, like their life, manage some of those pragmatics in order to, and logistics in order to get to their session. And it certainly is it is certainly an issue of convenience, which is helpful, but also it provides some schedules, or it provides scheduling, scaffolding, or support for individuals who have difficulty adhering to strict schedules. Also, multi-device access has been shown to be really supportive of individuals in attending their sessions. The sheer convenience of being able to pull out your mobile phone or your smartphone, to work on a tablet, to sit in your car and do sessions, as well as the traditional desktop or laptop computer. This allows individuals to connect from different locations, from different devices, and again, reducing some of these barriers to, logistical barriers to having their therapeutic intervention or support. What does the previous research say? The previous research says that from a clinical standpoint, teletherapy is effective. It's as effective as in-person therapy for a variety of psychological disorders, including ADHD, and it offers what we've been talking about in these key features, from convenience all the way to flexibility. From again, the teletherapy feature itself is the flexible scheduling, the automated reminders, and they have been shown to improve engagement within therapy, reduce dropout rates, especially with those who have ADHD. When we look at in-person and teletherapy, a meta-analysis of multiple empirical studies show that teletherapy certainly increases attendance and engagement compared to in-person traditional therapy. So there's some gaps in the literature, and we're going to go over those. When we talk about ADHD and teletherapy, there is a lack in the literature of what subtypes are more effectively supported with teletherapy. So the question is, what do we know about individuals who are inattentive? Who have attentional issues, or they have impulsivity or hyperactivity issues. What technology features of the platform, in its reminders, in its dashboard, provides support in order to increase attendance and treatment adherence? So we don't know that. We also don't know if there's any customization features that help individuals given their subtype. So we should look into that, as the study does. We also don't know what the long-term impact is. Is there a sustained effectiveness of teletherapy given the features? And we need that to be investigated, and Spencer and Team 2020 proposed that in their future research sections. So this study addresses these 5 here. So specific impact of teletherapy feature on the subtypes. I looked at the effectiveness of which features that enhanced engagement. I compared attendance rates between teletherapy and in-person therapy, and then I also looked at which technological features supported which adult age groups. And then lastly, long-term effects of teletherapy features. As we go through these, the specific impact of teletherapy features on ADHD, most research does not differentiate between the subtypes when we compare it to the technological features that have influence. In my study, I examined how different teletherapy features such as automated reminders, flexible scheduling affected the attendance rates across various subtypes. Again, that was lacking in the literature. For the effectiveness of technological features and enhancing engagement, again, limited within the research literature. And I looked at improving attendance and engagement across a 15-week program so that I could understand which features contributed to therapeutic outcomes. I compared, or there are some, as for the comparison between teletherapy and in-person therapy, some research does compare these, but there needed to be a more robust comparison with detailed data on attendance and engagement. And I compared attendance data from teletherapy sessions conducted on Carepatron, which is a telehealth platform, with previous in-person therapy data. And I did direct comparisons in order to evaluate the effectiveness of teletherapy related to traditional in-person therapy. And then for the different age groups, that was something that I looked at, and I'll present findings here shortly. And then for the long-term effects, although my focus was 15 weeks, it does offer some valuable data on at least the short-term effectiveness, but it also sets the stage for future research to look at the long-term impact. Now let's move to the study objective. My objective simply was to evaluate the effectiveness of teletherapy features in improving attendance and engagement across a 15-week program for adults with ADHD, and I compared those results with previous in-person therapy sessions. I'll tell you how I did it methodologically. The participants, 15-week teletherapy program, ages 18 to 65. They came to session, their intake with a formal ADHD diagnosis. It was reconfirmed, reassessed by a licensed clinician. And we used the ASRS 1.1 in order to diagnose the subtype. The participant had to have a history of previous in-person therapy, specifically for their ADHD, from a different service provider. And we verified that through collateral data obtained directly from the previous practitioner. The participants had to have basic proficiency with Carepatron and were provided training if they so asked. They needed to be able to navigate the video calls, accessing the reminders, show some familiarity with self-scheduling features, and we excluded anyone who had any major comorbid mental health conditions, including severe depression, bipolar disorder, and autism spectrum disorders. The setting for recruitment was an outpatient teletherapy clinic, which specializes in LGBTQIA+ issues, neurodiversity, and suicide focus for online counseling. And the recruitment method was indirect, in which there was voluntary treatment sought by the clients or the candidates themselves. The initial screening is as such. We did an ADHD diagnostic assessment, we reviewed the previous treatment history through collateral data, and we evaluated their technological skills and provided them any training if they needed it. The detailed study, obviously we included the purpose, procedure, and potential risk and benefits to the client. We obtained their informed consent for treatment and being enrolled in this study. Let's look at the statistical analyses, which is actually my favorite part. It was very comprehensive, so I look forward to going through this with you. The descriptive statistics. I looked at mean, median, standard deviation, some of the very common demographics, but they were extensive. I looked at age, educational attainment, employment status, as well as frequency distribution of the ADHD subtypes and the attendance. I compared, then I did some inferential statistics. I compared with previous in-person therapy attendance. I analyzed the features, influence on attendance. I did a subgroup analysis and regression. And then I did a bunch of sensitivity analyses to determine if I handled the data correctly. So I did a deviation of normality assumption. I tested the impact of deviation from normative assumptions and regression residuals. I employed non-parametric or parametric tests to evaluate consistency of the results under different distributional assumptions. For the handling of missing data, I assessed the influence of different imputation methods on the study outcomes, including mean imputation, multiple imputation, and complete case analysis. For the impact of outliers and influential data points, I evaluated the effect of outliers and influential points on the regression results using techniques like Cook's distance and leveraging statistics. For the alternative model specifications, I tested the robustness of the core findings with different model structures. Variations were tested where inclusion of different interaction terms, variations in covariance. As for the effects on data transformation, I examined those on the results using several transformations, logarithmic as well as square root. So let's get to the results. For the participants, 47 adults with ADHD were included in this study with a mean age of 34.5, age range 22 to 55, and we had a gender distribution of 22 women, 7 men, 6 trans men, and 12 non-binary individuals, no trans women. Educational level is as such. It ranged from high school diploma, bachelor's, and graduate's degree with 10, 18, and 19 participants respectively. The employment status was 22, which was the majority. Nearly 50% were full-time, about a quarter part-time, 17% unemployed, and a little under 15% self-employed. The ADHD subtype distribution was as such: 31.9%, a little over 25%, 42.6%. The mean attendance rate was 85.4%. And when we look at the ADHD subtype distribution, they are about the same. 87% if you had inattentive subtype, 82.1% if it was hyperactivity or hyperactive impulsive type, and combined type 86. There was a moderate positive correlation in the age analysis, which implies that older participants had a slightly higher attendance rate. When we looked at the educational attainment analysis, it trends towards significant difference. The interpretation of those results is that it suggests that a trend towards difference in attendance rates is based on educational level, although it does not reach conventional levels of statistical significance given a p-value of greater than 0.05. You'll note here that the p-value is 0.068, which is why it trends towards significant differences. And there's some potential impact of education on attendance. So from an education level influence, the trend implies that educational attainment might influence attendance rate, although again, it could be related to better developed organizational skill or higher motivation within the participant. This needs to be investigated further. While it's not statistically significant, again, it trends towards significant difference, and it does warrant further exploration. And future studies should investigate the role of educational level on a much or in more depth, as well as a larger sample size, in order to clarify whether or not there is an effect here. Then we have the employment status analysis, which showed that there was no significant difference across the employment statuses. So regardless if you were full-time, part-time, unemployed, or self-employed, it did not seem to have or make a difference on an individual attending their sessions routinely and consistently. When we looked at the in-person versus teletherapy, we used paired t-testing and looked at the effect size. And as you can see, there was a significant increase in attendance with teletherapy compared to in-person, and the effect size was large. When we look at when we looked at the influences of specific features on attendance, we saw positive correlation with automated reminders and positive correlation with self-scheduling tools. When we looked at the subgroup analysis, we saw some significant differences amongst ADHD subtypes, in which inattentive ADHD subtype had significantly higher attendance in comparison to the hyperactivity impulsive subtype. A regression showed not to have a significant predictor when controlling for technology features. Overall, the findings of the sensitivity analysis is that the teletherapy features significantly improve attendance rates, and the results remain robust across various analyses. I looked at deviation of normality assumptions, the handling of the missing data, as I mentioned previously, impact of outliers and influential data points, alternative model specifications, and effect on data transformations. That leads us to our discussion as we head towards the end of this presentation. There are some interpretation of these findings. So we found older participants showed higher attendance rates, likely due to more developed compensation strategies for managing their ADHD symptoms prior to therapy. So they acquired that across their lifespan, and that their established routines and organizational skills most likely were the influential factor for adherence to attendance. Younger participants, despite their greater technology competency, they didn't demonstrate significantly higher attendance. So this finding suggests that technology proficiency alone does not guarantee improved adherence, which highlights some of the challenges in integrating teletherapy into daily routines and managing distractions. As for the educational level, the trend was not statistically significant, but it trended towards, in which individuals holding graduate degrees potentially attended more regularly. And the issue with our finding is that because it trends with a larger sample size, we might find it statistically significant. As for the employment status, our study showed no significant impact beyond employment, such as personal motivation, engagement strategies, which might have played a more crucial role in determining attendance. Technology features. Overall, the teletherapy features, particularly automated reminders and self-scheduling options, positively impacted attendance rates. This aligns with previous research emphasizing the benefits of flexible scheduling and external prompts in enhancing adherence. Automated reminders, they served as external cues, which are particularly useful for individuals with ADHD who struggle with time management organization. This supports the notion that external prompts can aid in managing executive functioning deficits. There's flexibility within the self-scheduling options, which allows participants to choose their appointment times that fit their personal schedule, reduce conflicts and missed sessions, and accommodates any or accommodates enhanced adherence as rescheduling options are available. User-friendly interface. There was a usability increase in the technology of Carepatron, which is the platform that was used, given that it had multiple devices and did not require much technology competency in order to navigate. There were some personal and contextual factors. So while the technological features facilitate attendance, engagement levels still depended on personal motivation and support systems. So a combination of individual and contextual factors is crucial for maximizing therapeutic outcome. And then individual needs and strengths. So our study findings highlighted the need of personal teletherapy approaches that consider individual differences such as age, educational background, and technological proficiency to improve engagement and effectiveness. Here are my reference. I will go through them, and you're welcome to pause at any point in order to see them more clearly. 1, 2, 3, 4, and I thank you for your time today.